Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, today is the seventh and last episode of our series of discussion on pregnancy-specific liver diseases. In this whole series, initially we discussed the physiological changes in the liver functions. Then we started our case discussions. First, we discussed the hyperemesis gravidarum. Then we discussed the intrahepatic cholestasis of pregnancy. Then we discussed the pre-eclampsia and eclampsia. Then we discussed the HELP syndrome. And lastly, we discussed the hepatic rupture. Today, we are discussing the last episode, last case history of these episodes, and I hope that you have found this series helpful for the clinical management of pregnant ladies with liver diseases. Case history number 6. It's a case history of 31 years old lady, 28 weeks pregnant, who presented with fatigue, nausea, vomiting, abdominal pain, and jaundice. On examination, BP 155 by 100, mild ascites and pedal edema. Liver function tests: bilirubin 5.7, ALT 543, AST 398, alkaline phosphatase 200. So the LFTs are deranged. CBC hemoglobin 9.1, platelet 98,000. Other labs: urea 70 milligram, creatinine 2.6, uric acid 7.8, RBS 90, PTINR 2.2, D-dimers 450, urinary protein double plus, and normal electrolytes. So 31 years old, 28 weeks pregnant lady with these symptoms: blood pressure, ascites, edema, raised LFTs, and these are the labs. So the question is, what is the most probable diagnosis? You write down with you, and let's see if we are correct. And what will you treat with? How will you treat her? This is a case of acute fatty liver of pregnancy. This is last of the 6 pregnancy-specific liver disorders which we have discussed in these series. First, we discussed hyperemesis gravidarum, then intrahepatic cholestasis, then pre-eclampsia, then HELP syndrome, and lastly, the hepatic hematoma and rupture. This is the last of the 6 acute fatty liver of pregnancy. The diagnostic criteria: there's Swanisa criteria of acute fatty liver of pregnancy. These are the features, and 6 or more of the following features are required for diagnosis of acute fatty liver of pregnancy in the absence of another cause. So it's a big spectrum: clinical features, ultrasound features, lab features, and even histology features. The clinical features are nausea and vomiting, abdominal pain, polyarthritis nodosa, polydipsia and polyuria, encephalopathy. So 4 clinical features, symptoms rather, I must say: nausea and vomiting, abdominal pain, polydipsia, polyuria, encephalopathy. And lab features: bilirubin hypoglycemia less than 72, leukocytosis, AST/ALT more than 42, AKI or creatinine more than 1.75, coagulopathy, ammonia, and uric acid. So 4 clinical features and 8 lab features: 1, 2, 3, 4, 5, 6, 7, 8. And then one on ultrasound, ascites are echogenic liver. 13, and if biopsy is done, which is not done in routine, then microvascular steatosis on liver biopsy. So out of these 14, at least 6 should be present to make the diagnosis of acute fatty liver of pregnancy. Ultrasound and CT scan often shows fatty infiltration of the liver. If liver biopsy was done, it shows microvesicular steatosis, although widespread inflammation or necrosis is not typically seen. Acute fatty liver of pregnancy is a rare obstetric emergency. This is an emergency that occurs most often in the third trimester with an incidence of 1 in 7,000 to 15,000 deliveries. It's a rare one, but it's an obstetric emergency. Maternal mortality is estimated around 10 to 15%. About 10% of patients will have DIC. And half of the patients may have associated pre-eclampsia. Like in our patients, there were features of pre-eclampsia. Hepatic encephalopathy occurs later and should immediately alert the physician to the possibility of acute fatty liver of pregnancy. In severe untreated cases, rapid progression over a few hours to days to acute liver failure with coma, hypoglycaemia, renal failure, and coagulopathy ensue, and high risk of maternal and fetal death is there. The pathogenesis of acute fatty liver of pregnancy is related to a defect in beta oxidation of long-chain fatty acids in the fetus. And it leads to this acute fatty liver of pregnancy. So in the fetus, there is defect in the beta oxidation of the long-chain fatty acids. The most commonly invoked molecular defect is a mutation in the LCHART, which stands for long-chain 3-hydroxyacyl CoA dehydrogenase. Mothers who are heterogeneous for LCHART are at risk. This deficiency is related to a common G152.8C mutation. The disorder arises from excess unmetabolized long-chain fatty acids generated by the fetus, homozygous for LCHART mutation, which passes to the mother who is LCHART mutation heterogeneous, leading to subsequent hepatotoxicity. So in the fetus, there is defect in the beta oxidation, and when these unmetabolized long-chain fatty acids, they cross the placenta and passes to the mother, then they leads to hepatotoxicity. These deposit in the mother liver and leads to acute fatty liver of pregnancy. Although LCHART is implicated in the disease, other disorders of beta oxidation of long-chain fatty acids have been associated with acute fatty liver of pregnancy. There's at least one case report of a deficiency in palmitoyl transferase leading to acute fatty liver of pregnancy. About 20% of women who develop acute fatty liver of pregnancy carry LCHART deficient fetuses. Therefore, screening of the newborn of acute fatty liver mothers for this mutation can be life-saving. So this is important that you, when the mother gives birth to a baby, to an infant and she was having acute fatty liver of pregnancy, then these newborns should be checked for this mutation. Newborns with LCHART deficiency present with a metabolic crisis in the first year of life and can experience sudden death at a few months of age. So this is important. So if all children born to the patients with acute fatty liver of pregnancy must be screened for this. LCHART deficient newborns can be treated with dietary modifications with dramatic reduction in morbidity and mortality. So the diagnosis of acute fatty liver of pregnancy is important for the mother as well as for the newborn as well. This is the in the fetus when there is LCHART or other FAO deficiency, it leads to the mitochondrial beta oxidation of the fatty acid is faulty. So there is placental oxidative stress, mitochondrial dysfunction, lipid accumulation, and lipotoxicity. And then it leads to, when it enters the mother, the LCHART or mother FAO deficiency heterogeneous in the circulation, it leads to here the high 3-hydroxy fatty acids, rise in free fatty acids, rise in oxidative stress, and decrease in antioxidants. And then it leads in the mother liver microvesicular steatosis, mitochondrial dysfunction, leading to raised ROS species, raised inflammatory pathways, and raised apoptosis. And all this leads to the acute fatty liver of pregnancy. Management, how the management should be. It should include prompt delivery. Laboratory and clinical abnormalities may persist for up to a week postpartum. Liver transplantation is an option if liver failure does not improve after delivery. So it's a potential candidate for liver transplant. The mother is fetal mortality is estimated at 20%, developmental delay, hypoglycaemia, and striated muscle dysfunction are all potential complications. Therapy with medium chain fatty acids is often necessary for infants with homozygous LCHART deficiency. So, my dear colleagues, we discussed the pregnancy-specific liver disorders, and we saw that in the first trimester, this is the hyperemesis gravidarum. In the second and third trimester, this is the intrahepatic cholecystitis of pregnancy. In the same second and third trimester, the pre-eclampsia and eclampsia. Then the HELP syndrome in the third trimester and early postpartum. Then we saw in the second and third trimester, the hepatic hematoma and rupture. And then the acute fatty liver of pregnancy, which most commonly happens in the third trimester. The key points from this whole series of 7 vlogs is that pregnancy-specific liver diseases can be differentiated based on their timing within pregnancy, clinical features, and laboratory values. Management of hyperemesis gravidarum is supportive. Intrahepatic cholecystitis of pregnancy is managed pharmacologically and with early delivery at 37 weeks of gestation. And hypertension-related diseases, that is differentiating between hemolysis, elevated liver enzymes, low platelet syndrome, and acute fatty liver of pregnancy is challenging. At times it becomes challenging. And criteria for both diseases have been developed to aid diagnosis. That's the reason we have got clear-cut criteria for HELP and clear-cut criteria for acute fatty liver of pregnancy. Prompt delivery of the fetus is the most important management for pre-eclampsia with liver involvement, HELP syndrome, and acute fatty liver of pregnancy. Prognosis of pregnancy-specific liver diseases has improved in recent years with earlier diagnosis and improvement in multidisciplinary management. And it has changed the whole perspective of pregnancy-specific liver disease management. In the majority of cases, pregnancy-specific liver diseases have no long-term impact on liver function. So, to summarize all these, this is the chart giving to all these features. The timing of presentation, the hyperemesis gravidarum in the first trimester, main clinical features is severe nausea and vomiting and dehydration, weight loss, ALT, AST, 1 to 5 time raised, bilirubin remains normal, bile acids remains normal, platelets remains normal, hemolysis is not present, LDH is normal, fibrinogen is normal, hypoglycemia is not there, uric acid remains normal, creatinine is raised. Key steps in management is supportive rehydration and antiemetics. Differential diagnoses include hepatitis, cholecystitis, peptic ulcer, gastroenteritis, and pancreatitis, and complications may be preterm birth, fetal growth retardation, restriction, vernix encephalopathy of the mother. When we come to the intrahepatic cholecystitis of pregnancy, the timing of presentation is the second and third trimester. There's the main clinical features is pruritus and jaundice. ALT and AST are 1 to 8 times raised. Bilirubin is now mildly raised 1 to 6 times. Bile acids are more than 10 macromole per liter. The platelets are normal. There is no hemolysis. LDH is normal. Fibrinogen is normal. There is no hypoglycemia. Uric acid is normal. Creatinine is normal. Key steps in the management are ursodeoxycholic acid and delivery at 37 weeks. Differential diagnoses are cholelithiasis, viral hepatitis, autoimmune liver disease, and the complications are preterm birth, fetal distress, and stillbirth. When we come to the pre-eclampsia with hepatic impairment or eclampsia with hepatic impairment, the timing of presentation is after 20 weeks. Main clinical features is abdominal pain, hypertension, proteinuria, and headache. The ALT is 2 to 10 times raised. Bilirubin remains normal. Bile acids are normal. Platelets may be low. There is no hemolysis. LDH may be normal or raised. Fibrinogen is normal. The hypoglycemia is not there. The uric acid is raised. The creatinine may be normal or raised. The key steps in management is blood pressure control, delivery after 34 weeks, differential diagnosis, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, SLE exacerbation, or septic shock. And the complications is liver hematoma, rupture, infarction, liver infarction, pulmonary edema, cerebral hemorrhage, preterm birth, fetal growth, and restriction. When we come to the HELP syndrome, the timing of presentation is third trimester. Main clinical features is abdominal pain, vomiting, hypertension, proteinuria, and headaches. The ALT and AST, they are 2 to 3 times upper limit normal, 2 to 30 times rather. Bilirubin 1.5 to 6 times. Bile acids are normal. The platelets are mild to moderately or severely low. The hemolysis is present. The LDH is raised. Fibrinogen is normal. There is no hypoglycemia. Uric acid is raised. Creatinine may be normal or raised. The key steps in the management is delivery, platelet transfusions, blood pressure control. The differential diagnosis is hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, the SLE, exacerbation, and septic shock. And the complications are liver hematoma, rupture, infarction, pulmonary edema, cerebral hemorrhage, DIC, the preterm birth, fetal growth restriction. Now, the last which we discussed today is the acute fatty liver of pregnancy. This is in the third trimester. Main clinical feature is abdominal pain, vomiting, jaundice, encephalopathy. ALT, AST may be 5 to 15 times raised. The bilirubin is also raised 6 to 8 times. The bile acids are normal. Platelets are low. The hemolysis is present over here. LDH is raised. The fibrinogen, typically here they are low, and there is hypoglycemia. The uric acid may be raised. The creatinine is mildly to moderately raised. The key steps in management is delivery and intensive care. The differential diagnoses are hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, paracetamol toxicity, hepatitis, SLE exacerbation, and complications are acute liver failure, DIC, postpartum hemorrhage, acute renal failure, and gastrointestinal bleeding. So this is a summary of all the 7 episodes which we went through till now, and the six the diseases at the timing of presentation, they vary. Then the main clinical features, how they are different from one another. Then on the labs, how different from one another. Then what are the key steps? This is comparative slide. What is the differential diagnosis and what are the complications? So, dear colleagues, I believe and I hope that this series has added to your understanding to the pregnancy specific liver diseases. What are they? What are their causes? What are their criteria of diagnosis? What is their impact on pregnancy? How to manage these, and what is the outcome of the fetal outcome in these diseases? I do request that please share all these with your colleagues, with your juniors, with your seniors, and I shall be waiting for your kind comments in the comment section on these. If you have got any query, if you have got any suggestions, if you have got any want to share your experience, you are most welcome, because these are the learning source for me and for all of us, and we learn from one another. So this I wanted to share with you my treatment approach whenever a patient's my opinion is asked regarding the any disease, liver disease in the pregnancy. The pregnant lady presents to me with liver disease. This is how I approach these patients. So by this, I pay thanks to you, all of you, for being with me in this whole series. And inshallah, soon we will start another similar series, and with an attempt to simplify the process of identification, diagnosis, and management of liver diseases